Hello friends, welcome to my channel Clinical Biochemistry with Dr. P.K. Pravakar. Today I am going to talk about another mineral of our body, and one of the important mineral we can call it, that is iron. So we will see the sources of iron, recommended dietary allowance of the iron, their functions in our body, regulations, and lastly we will see the abnormality. This is the chemical composition, chemical properties of iron. Atomic number of iron is 26. Its a symbol normally we are going to call Fe. And normally it exists in two different forms, most commonly uh, +2 and +3 forms in our body. Other than that one, it is also going to exist in +4 and +6 forms. So this is the chemical properties of iron. If you'll see, iron makes up to 5% of Earth's crust, and it is the second in the abundance after aluminium among the metal, and fourth in abundance behind oxygen, silicon, and aluminium. Now, iron is called as trace element. Why iron is called as trace element? Because its requirement in our body is very low. Uh, we have already make a video on the classification of minerals, where we have classified all the minerals into two classes: micro minerals and macro minerals, depending on their requirement. Any element, any minerals whose requirement is more than 100 mg per day, we are going to call it macro minerals. And if requirement is less than 100 mg per day, we are going to call micro minerals, or it is also called as trace elements. So iron's requirement is less than 100 mg per day, so it is called as trace element. The total content of iron in our body is adult body is 5 to 3 to 5 gram, and in this 3 to 5 gram iron which is going to be stored in our body, 75% of this one occurs in erythrocyte, RBC. We will have the content also, and that is the main constituent of hemoglobin in the form of heme. At least 5% of our body's iron is present in myoglobin of the muscles. There also it is associated with the pigment. Heme is the most predominant iron containing substance. And now, if you might have heard about heme is present in all most of the many of the enzymes are there, like all the cytochromes, cytochrome oxidase, cytochrome, different other forms, where we are having heme body there. So they contains iron sulfur centers and other things. So there we are having iron is there. So this heme is constituents of many proteins, many enzymes, and these proteins are called as heme proteins. Some of the examples of heme proteins are hemoglobin, myoglobin, cytochromes, xanthine oxidase, catalase, tryptophan pyrrolase, peroxidase. These all elements, all enzymes contains heme. Or certain other protein also contains non-heme iron, that is transferrin, ferritin, hemosiderin. And normally in our body, these are the iron binding proteins, which helps them either in the storage or in the transportations. Later on, we will see what is the function of transferrin, what is the function of ferritin, what is the function of hemosiderin. We will see later on. So iron, how it is going to be stored? We are having iron stored in the body. 65% of iron is carried by RBC, that is in the form of heme. 30% is stored in as in ferritin in the liver, bone marrow, and spleen. Means ferritin is a protein which normally helps in the storage of iron. So whenever our body is try to means wants to store, or they are going to store iron, that iron will be associated with the ferritin. So that is in the liver, bone marrow, and spleen, iron will be stored with the ferritin. Transportation, when iron is going to be transported, that time it will be mainly associated with the transferrin. So 65% is in the RBC, 30% stored, 4% stored as myoglobins, skeletal muscles, and rest in the transit throughout the body associated with transferrin mainly, and some other iron binding protein. So this is the iron stored in our body in different places and different forms. Now, if you'll say in male, roughly we are having 4 gram of iron, and in the female we are having slightly less, that is 2 to 3 gram of iron in the body. So this already we have seen it. Iron storage 67% in the RBC, 30% associated with the storage protein, that is ferritin, 3% in different other places. So this is iron distribution in the body. We are having, I have told you already, 3 to 5 gram of iron we are having. Out of that one, maximum iron is associated with roughly to 200,300, that is 2.3 gram of iron in the hemoglobin. Approximately 10% is present in the muscle fibers. Well, so we are going to see here muscle fiber we are having, and the enzymes and the Cofactor. So 350, this will be milligram. So that is the roughly 10% of the in the present in the muscle fiber, in the myoglobins and other tissue. The remaining body iron is stored in the liver. We are having 200 mg in the liver. Then we are also having in the bone marrow 150, roughly 150 mg in the bone marrow. Sorry. On an average, roughly 1 to 2 mg of iron is lost from the body on a daily basis through desquamation of the epithelial cells of the skin, GIT tract, bile ducts, and urinary tract via blood loss during the menstrual and iron absorption in the digestion. So this is roughly 1 to 2 milligram will be lost during different other processes. We are going to absorb roughly 1 to 2 mg daily, and through for phagocytosis and for different other processes, we are having roughly 500 mg in the macrophages. Now, for this absorption, we are going to, so our requirement is very low. We are having 3 to 5 gram. Absorption is very less. We don't lose it too much. Normally, this iron is going to be recycled too many times. So later on, we will see iron is called as one-way substance. I will explain you why it is called as one-way substance. Not only in our body, iron is associated with different other proteins in different other kind of organisms like iron. Here you can see in the human, the majority of the our vertebrates, it is iron. Our blood color is red, and that is because of hemoglobin, and that hemoglobin is containing iron. Here you can see it, and because of this iron, blood color is red. So this hemoglobin is a protein which is found in blood and built up from the substance containing heme, and they helps in the oxygen transportation. If we'll say we are having another protein that contains in place of heme, they contains copper, and that is hemocyanin. So that is the blood color presented in our case because of hemoglobin. For the same purpose, they are having copper containing blood pigment, that is in the spiders, crustaceans, some mollusks, and octopus and squids, and this is for doing the same purposes. Similarly, green colored blood is present in some segmented worms, some leeches, some other marine worms, and that is because of again iron containing chlorochlorine. And then violet colored blood is present in some of the marine worms, including peanut worms, penis worms, and brachiopods. And there also we are having iron containing proteins, iron containing component, that is hemoerythrin. So, oscillated ice fish blood is colorless, and it has no oxygen carrying proteins. Instead of using hemoglobin for to transport oxygen around the body, the oscillated fish uses blood plasma to move oxygen. So normally, if you see for transportation of oxygen, we are having hemoglobin. Squids, mollusk, octopus having hemocyanin. Chlorochlorine is in some of the leeches, some of the segmented worms, some penis worms, peanut worms. They are having hemoerythrin. Except this hemocyanin, all other blood oxygen carrying proteins are containing iron. In the oscillated ice fish, they don't have any oxygen carrying proteins like we have already seen it. They are having their oxygen is going to be transported through plasma. This so what is the function of iron in our body? Iron, we have already seen where it's present. It's having number of functions. If you'll see, biochemical function of iron is uh, it's for the hemoglobin formations, because hemoglobin having two component, heme plus globin. So for heme formations we require iron. For brain functions we require iron. For the muscle function in the myoglobins, you have seen, we require iron. For the regulation of body temperatures we require iron. For phagocytosis, Fenton's reactions to generate free radicals, we require uh, iron, and that boosts our immunity. Treatment of fatigueness, we require iron. Restless leg syndromes, if we don't have, uh, because if in absence of iron, it is going to cause anemia. So iron normally exerts many functions through for the oxygen transportation of oxygen. Hemoglobin we are having, which transport oxygen as well as carbon dioxide. Other than this one, other than these functions, cytochromes and certain non-heme proteins are necessary for electron transportation, electron transport chain, and oxidative phosphorylation. So for ATP synthesis, ATP formations, productions, we require iron. Other than that one, some of the enzymes like peroxidase, lysosomal enzymes, which requires for phagocytosis or killing of bacteria, and in the neutrophils, we require oxygen. So these are the different function of iron in our body. The some of the food content which have sufficient amount of iron, they are spinach, figs, lentils, kidney beans, potatoes, oats, soybean. So these are the 13 high iron containing compounds or food. So these are the major sources of iron in our body. If you see the requirement of iron RDA value, adult male requires, if you see male, roughly according to age, it's varying, but on an average, if you see the adult men, they require roughly up to 10 mg per day. In case of menstruation, menstrual women, so who is in the menstrual fertility during fertile lifetime, they require slightly higher content of iron because of the blood loss every month. Their requirement will be 18 mg. So in this is the 18 mg per day is the requirement. In case of pregnant and lactating women, requirement is again very high. Roughly it goes up to 40 mg per day in case of pregnancy. Other than that one, according to age, it is varying. So three important RDA value you need to remember: 10 mg per day in the adult male. In adult female, it is 18 mg per day, and in lactating and pregnant women, it can go up to 40 mg per day. So this is the RDA value for the iron. Now, if you see the absorption of iron, its transportation and its storage in our body. Iron is mainly absorbed in the stomach, in the duodenum. In the normal people, about 10% of the dietary iron is going to be usually absorbed. 90% is going to be excreted through the defecations. In an iron deficient individuals and the growing children, a much higher proportion of dietary iron is absorbed to meet the necessary body requirement. Means as per your body requirement, iron is going to be absorbed. If I am healthy, I am going to absorb only 10%. And if a person is anemic, their body requirement will be little bit high. So their absorption will be higher than the 10%. So they are going to increase the absorption. And how it is going to increase the absorption, we will talk about when it is going to be regulated. There are a specific proteins that is called as hepcidin. If you want to write it, you can write it hepcidin. Hepcidin. So this normally helps in the absorption through the cells. So there we will talk later on. Iron is mostly found in the food in the ferric form, Fe3 plus forms, associated with the different proteins or organic acids. In the GIT tract, in our intestinal tract, the acidic content of the iron food, acidic content of the GIT tract, or by because of HCl, or some of the other vitamins, vitamin C, iron Fe3 plus is released from the food because of the gastric HCl. It is going to be released, so Fe3 is free from this protein or organic compound. Then reduce some of the reducing substance like vitamin C and cysteine convert this Fe3 plus into Fe2 plus. After once it is going to be converted from Fe3 plus to Fe2 plus, then this Fe2 plus is going to be soluble and it is going to be readily absorbed. Means iron is going to be transported in the form of Fe2 plus or in the ferrous form. So this is the transportable form of iron. When it is iron is going to be stored associated with proteins, that time it is associated with the in the Fe3 plus form. So this is the storage form, Fe3 plus storage form, ferrous Fe2 plus is the transportable forms. So this is we are having iron. So stomach HCl changes Fe3 plus into Fe2 plus. So whatever iron we are going to have, that is going to be ingested. 10 to 15% will be absorbed in the form of Fe2 plus. Here it is Fe3 plus. This Fe3 plus is going to be converted to Fe2 plus because of uh, vitamin C and other things. Then once it is going to be absorbed, apoferritin once it will be transported, it is going to be bind with Fe3 plus. So ferritin, we will see later on, transferrin synthesized in the liver. So transferrin is for the transportation, ferritin is for the storage. So this is the whole process of which is going to have in the body. So we are going to take food. In this food, Fe plus, Fe will be in the form of 3 plus, uh, ferric form. Because of HCl and organic acid, this Fe3 plus is going to be released from the food content of proteins and other associated organic acids. This Fe3 plus is going to be converted into Fe2 plus because of ascorbic acid and cysteine, and this all occurs into the lumen of the GI tract during the digestion. So when this is Fe3 plus is going to be converted into Fe2 plus, this is going to be transported into the mucosal cells. This is the luminal cells. So in this luminal cells, this Fe2 plus will be transported through a specific transporter proteins, and that transporter protein is called as divalent metal ion transporter. Divalent transporter ion metal ion transporter. It's DMT1. So DMT1 is a transporter which is present here. So it is going to be absorbed in the Fe2 plus forms. Now this Fe2 plus form is having two different fates. One fate is it can go to the blood circulations in the same form Fe2 plus forms, or it will be stored. When it is going to be transported into the blood circulation, it is directly transported into Fe2 plus forms, and there we are having another transporters. The name of this transporter is ferroportin. So here we are having ferroportin, Ferro portin. So here we are having DMT1, here we are having ferroportin. If our body blood does not require iron, so then this iron will be stored. So first, iron, we cannot store iron in this +2 form, so this iron need to be converted into Fe3 plus form, and there we are having ferrooxidase which converts Fe2 plus into Fe3 plus. Now this Fe3 plus iron is going to be combined with apoferritin. So apoferritin and iron converted into a ferritin. So ferritin is a protein where apoferritin binds with Fe3 plus. So this is the storage form of iron. When our body requires iron, so that time this ferroprotein again going to be dissociated, and this iron which is in the Fe3 plus form going to be reduced to Fe2 plus forms by ferroreductase, and then again it is going to be taken into the blood circulation by ferroportin. Into the blood circulation, when it is reaching to the blood circulations, there again it cannot circulate it. So this is just a transporting portion. When it is going to be circulated, so this Fe2 plus will be converted into Fe3 plus again by ceruloplasmin or ferrooxidase 2. So we are having two different proteins which is going to oxidize iron, one into the luminal cells, that is ferrooxidase, and second ferrooxidase 2 or ceruloplasmin. This Fe3 plus is going to be combined with another transferrin and converted into transferrin. So transferrin is the transporter protein of iron, where apotransferrin is combined with Fe3 plus. This transferrin is going to be transported through blood circulation, and it reaches to the liver. Again, when it is reaching to the liver, again it is going to combine with ferritin and hemosiderin, or it will go to the bone marrow for the hemoglobin synthesis, muscle for myoglobin, or for different other functions. So this is how it is going to be reaching absorption, transportation, and storage going to occur. So the plasma transferrin, which concentration is roughly 250 mg per dl, can binds with 400 mg of iron per dl. This is known as total iron binding capacity, TIBC, of plasma. This is the which I was talking about, the receptors. So iron, here we are having Fe3 plus. Sorry. So the non-heme iron is reduced from Fe3 plus to Fe2 plus, either chemically by HCl, or through the absorption action of DCYTB. So when it is going to be transported, so this is the DMT1, divalent metal ion transporter 1. So it is going to be taken into the luminal cell. This is the luminal cell of our lumen. In this case, this is Fe2 plus. Again, I have told you already, so you are knowing it is having two fate. Either it is going to be transported into the blood circulations uh, and it is going to out into the blood circulation by ferroportin, or it is going to be stored into the luminal cells where it is going to converted back into the Fe3 plus by ferrooxidase. So this is how it is going to be happen. So role of transferrin in our body, if you'll see, sorry. So this is iron. This is the transferrin protein, which is a beta one globulin proteins, that is apoferritin. This apoferritin combines with iron and converted to transferrin. So this transferrin having receptor means on the developing RBC, they are going to take it, carrying the blood into the protein. Transferrin release into iron into the RBC. So on RBC surface, developing RBC surfaces, we are having a receptor for transferrin, and this transferrin, which contains apotransferrin plus iron Fe3, combined comes and binds here, and iron will be released into the RBC, and transferrin is released from the iron. Transferrin capacity to bind iron, that is 240 to 360 microgram per dl. So second one is ferritin. Ferritin, normally I have told you, it is the storage protein of our body, a storage form of iron. So where we are having apoferritin cells. So this is which we are going to see apoferritin cell, that is of 24 units. So apoferritin cell plus ferric oxyhydride FeOOH. This is, that is in the into the core. So ferritin is bound almost in all cells of the body. Iron is supplied in the diet, and 10% of the ingested iron is absorbed in the small intestine. So iron carrying capacity protein is molecular 75,000. So this is ferritin. This is the same ferritin we are having, and where it is going to happen. So this is the apoferritin core, which is having 24 unit. Inside we are having ferric oxyhydride FeOOH, which is into the center, and this is going to be um, rapid oxidations diffuse through the pore of the cells and converted into Fe2 plus. This ferritin forms in serum. It gives Fe2 plus, which helps to form hemoglobin, heme proteins, cytochromes, and number of other things. This ferritin is one of the storage form of iron, which stores into the liver, spleen, bone marrow, RES, and GIT, gastrointestinal mucosal cells. Now, so this is overall summary of the its absorption, transportation, and distributions. Heme, myoglobin sources 15 to 30 mg per day intake through intestinal tract. We are going to take it. 5 to 10% is going to be absorbed. Rest is going to be released. This Fe3 normally in the food it is going to be present into Fe3 plus form. This Fe3 plus is converted to Fe2 plus by HCl, means released from in Fe3 plus, converted to Fe2 plus by the vitamin C and some other 16 other things. Then it is going to be absorbed mainly into the small intestine. Through the intestine, it is going to be regulated their absorption and secretions. Absorption, male roughly 0.15 to 1 mg absorption, female 1 to 1.5 mg absorption. Secretions and leftover is going to be excreted. So I have told you 90%, 90 to 95% is going to be released through the feces or through defecation process. Iron is stored in different places in the associated in the form of ferritin in the liver, spleen, bone marrow. Okay, it in the mucosal cells, ferritin is a temporary storage form of iron. A molecule of apoferritin, whose molecular weight is 5 lakh, can combine with 4,000 atom of iron. The maximum iron content of ferritin is on weight basis is 25%. Hemosiderin, we have seen that is another iron binding storage protein which can hold up to 35% of iron by weight. Hemosiderin normally accumulates in the body, spleen, liver when the supply of iron is going to be exceeded in the body demand, exceed of the body demand. And that hemosiderosis, we are having a disease that is called as hemosiderosis, when these accumulation of iron is going to occur in different body parts like spleen and liver. So hemosiderosis is another disease. Now there are a number of factors which is going to affect the iron absorption. So if we are having acidity, ascorbic acid or cysteine, normally it increases the absorption. In iron deficiency anemia, iron absorption is increased to 2 to 10 times compared to control or compared to normal. Some of the small proteins and peptides and amino acids which favors the iron uptake. So more iron uptake will be there. Some of the plant like phytates, which is found in cereals, oxalate, which is present in normally leafy vegetables, interfere and reduces the absorption of iron in our body. A diet which is having high phosphate content decreases iron absorption, while low phosphate is going to increase the iron absorption. Impaired decreased absorption of iron is observed during the malabsorption syndromes like steatorrhea. In patient with partial or total surgical removal of stomach or intestine, iron absorption is very severely impaired or reduced. Now, if you see iron in the already how it is going to be transported into the mucosal cells to the plasma and how it is going to be occurring. So we have already seen it. Enzyme, there are a number of enzymes in our body which requires iron as a cofactors. So these are some of the enzymes like econitase of the citric acid cycle, alcohol dehydrogenase, catalase, cytochrome C reductase, lipooxygenase, lysyl hydroxylase, NADH, ubiquinone reductase, phenylalanine hydroxylase, tyrosine hydroxylase, tryptophan hydroxylase, thyroid peroxidase, succinate ubiquinone reductase, steroyl coenzyme desaturase, ribonuclease reductase, uh, prolyl 4 hydroxylase. These all contains heme protein. So these are hemoproteins, which where iron works as a cofactor, and they are having iron sulfur centers. So normally, most commonly, these enzymes helps in the oxidation reduction reactions. Okay. Uh, one thing I have told you that iron is known as one-way substance. Why iron is known as one-way substance? Is iron metabolism is a unique as it operates in the closed system. It is very efficient, utilized, and normally it is going to be reutilized in our body many times. Further, iron losses from the body are very less. That is less than 1 mg per day. We are going to lose iron, which may occur through the bile, sweat, then hair loss. Okay, iron is not excreted into the urine. Thus, iron differs from the vitamins and other organic and inorganic substances which are either inactivated and excreted during the course of metabolic functions. Hence, iron is approximately regarded as a one-way substance. This is the roughly some of the facts about iron. 1 gram hemoglobin contains roughly 3.5 milligram of iron. 1 ml packed RBC contains 1 mg of iron. Iron intake on an average is 10 mg per day. Out of this, 10% is absorbed, 90% is going to be excreted. 20 to 25 mg per day required for erythropoiesis. Pregnancy or lactating women needs more iron. We have already seen up to 40 mg per day requirement is going. Iron stores, men is having roughly 1000 mg, female 3 to 500 mg, 10 to 20% stored as in the ferritin. Iron losses roughly very less than 1 mg per day in male and non-menstruating female, up to 2 mg per day during the menstrual cycle or menstruating women. Iron intake, more than 50% iron is absorbed if taken before 40 to 60 minutes of the food. Normal dietary iron takes 20 to 10 to 20 mg per day. Effect of food on iron absorption. Some of meat contains less absorption than dairy products, high fiber content foods. Coffee and tea also inhibits the absorption. Vitamin C increases absorption. Phytates, oxalates also decreases its absorption. What is the effect of pH on iron absorption? Acid and low pH favors the absorption. Alkaline or neutral pH favors the Fe3 plus state. Alkaline and neutral pH decreases the iron absorption. So this is some of the facts. Now come to the deficiency. The causes of iron, there are a number of causes which causes iron deficiency, like due to the defect in the absorption, blood losses due to specific health conditions, or because of accident or because of any injury, requirement during the pregnancy, sudden blood loss due to injury, excessive intake of polyphenols. Uh, because of all these things, or we are going to take less iron, So in all these cases, iron deficiency is going to happen. So iron deficiency anemia or microcytic hypochromic anemia is going to cause it. Okay, hemosiderosis is due to excessive absorption, excessive iron in the body. One of the you can call it Bantu tribes are there. We are going to talk about these two: iron deficiency anemia and microcytic hypochromic anemia. Bantu tribes in South Africa. Normally, what they are going to do, they normally takes they normally what do they they are attributed to a high intake of iron from the staple diet, corns, and their habit of cooking food in the iron pots. So they are having very much occurrence of hemosiderosis in the Bantu tribes of the South Africa. Hemochromatosis, this is the rare disease in which iron is directly deposited into the tissue, soft tissue, that is a liver, a spleen, pancreas, or a spleen. Hemosiderosis is sometimes accompanied by hemochromatosis, and bronze pigmentation of the skin occurs. Cirrhosis of the liver occurs. Pancreatic fibrosis are the manifestation of this disorder. This hemochromatosis called also called as bronze diabetes because of the bronze pigmentation. Now, if you see the iron deficiency anemia, this is the most prevalent nutritional disorder worldwide, including a well-developed country like USA also. Several factors are responsible for this iron deficiency anemia. These includes inadequate intake of inadequate intake of iron, defective absorption of iron, chronic blood loss, repeated pregnancies, hookworms infections. So these are some of the reasons which are going to cause iron deficiency anemia. Then second one is microcytic hypochromic anemia. Iron deficiency anemia mostly occurs in the growing children's, adolescent girls, pregnant, and lactating women. That is called as microcytic hypochromic anemia with reduced blood hemoglobin level is less than 12 mg, 12 gram per dl. So this is all about the diseases. Now, if you see iron increased serum iron level occurs in seen in case of hemolytic anemia, hemochromatosis or hemocirrhosis, multiple transfusions, iron therapy, lead poisoning, vitamin B6 deficiency, liver damage or acute hepatitis, nephritis, acute leukemia, iron overload syndrome. So, in all these contents, serum iron level going to rise. There are some other causes which ultimately going to cause decrease in the serum iron levels. That is iron deficiency anemia, inadequate absorption, cirrhosis, chronic blood loss, paroxysmal nocturnal hematuria, remission of pernicious anemia, chronic some of the chronic diseases like SLE, rheumatoid arthritis, 30% decrease of iron after every menstrual cycles, pregnancy mostly in the third trimester, inadequate absorption from the intestine, malabsorption, short bowel syndromes, malignancy, and chronic hematuria. These are the conditions, these are where iron content decreases in our body. So this is all about the iron. Hope you have understand it. If you have any query, any comments regarding iron or any other content of the biochemistry, you can write in the comment box. If you like the video, press the like button. If you have not subscribed my channel, please subscribe it. Thank you very much. Have a nice day.